Good morning, everybody. My name is Tadeusz Popiela. I am radiologist working in Kraków in the Department of Radiology of University Hospital, as well as a chair of radiology in Jagiellonian University. My main area of interest is interventional radiology, so I was asking today to give you some ideas of the main common procedures we are performing in interventional neuroradiology. I am on the lucky position because Professor Walecki already told you some main things about interventional radiology and also about interventional neuroradiology. So I only mentioned that as well as neuroradiology, interventional neuroradiology and peripheral interventional radiology constitutes on the interventional radiology as a wide variety of procedures. Today, I will concentrate on interventional neuroradiology and mainly endovascular procedures because they are most common diagnostic as well as the therapeutic procedures. First of all, I would like to start it with kind of description what kind of procedures I am going to talk about today. In 2017, there was a document which was created as a kind of consensus between the largest European scientific societies dealing with broadly understood interventional neuroradiology. In this document, there are mentioned the most common procedures like embolization, angioplasty, devices implantation, stents, coils, and let's say all the kind of flow disruptors, thrombectomy, percutaneous spinal head and neck procedures, and image-guided administration of the drugs. If someone says that neurointerventional radiology is the new or is the young field of interventional radiology, it's wrong. It's a mistake. It's Professor Walecki mentioned already about that. The first procedure was mentioned in 1930, last century, by Dr. Brooks, and he described the intervention in carotid cavernous fistula. But I'm not going to bore you all this milestone in the history of neurointervention, but I think that one of the most important is the last positions in 2005. There was introduced mechanical thrombectomy in treatment of acute cerebral ischemic strokes, and it's really take the treatment by storm. Because as I said before, I am going to talk mainly about intravascular procedures. We have four main type of examination. It's ultrasound, angio-MR, angio-CT, and at the end we have the digital subtraction angiography, so-called DSA. They are put on the list in such a way that I started with the less invasive and finished on the most invasive, so DSA. The DSA is invasive compared with the previous method, like angio-MR, angio-CT, or ultrasound. What is the definition of DSA? Because we must understand that DSA is the kind of gold standard. If we have the patients who are coming with symptoms of so-called neurological deficits, and we suspect that maybe they are come because of some problems with vascularity of the brain, and there is nothing in the ultrasound, in the angio-CT, angio-MR. In these examinations, we can find nothing. So and still the patients have the neurological deficits. So the DSA is on the last position, but is the gold standard. At the end, we must use and perform DSA to be sure that there is really nothing. So why is the most invasive? First of all, because we are using X-ray. Then because always to use X-ray, and if we want to see the vessels, we must inject the contrast agent. At the end, we must catheterize the right vessel, which is actually going to the area of the human body we want to see. We want to see the vessels, the pathology. So if we want to see, for example, brain, because we're talking about neurointerventional radiology, if we want to see the brain, the brain vessels, we must catheterize at least 3 main arterial trunks. It means the right and left common carotid arteries, and at least one of 2 vertebral arteries. And then we are sure that we will see all the vessels, the brain vessels. The DSA, the name, the digital subtraction angiography, what come from? Digital, it's because it's the digital acquisition. Angiography, it comes from Latin. It means that we are try to making visualization of the vessels, and subtraction. The problem is that we must realize that we are talking about brain, and outside the brain is skull, which is very dense structure. And to see vessels, we must inject the contrast media, the contrast agent. And the comfort of analyzes the contrast media in the vessels with the background, which is dense skull, is not very well. So we would like to subtract the background, subtract the bones. And how we can achieve it? In fact, the computer is doing it instead of us. The computer, which is guiding the angiograph, the X-ray machine, which is dedicated for our job. So the first acquisition is just, we are saying that this is acquisition of the mask. It means the acquisition of the background, just the bones. Then after we finish the first acquisition, the computer is turning on the automatic syringe, injecting the contrast agent, and then making the second acquisition. At the end of the second acquisition, is taking out the first one from the second one, and we can receive the subtracted image. This is the image on the right side of the monitor. So you can see that again, that the comfort of analysis, the comfort of assessment, the vessels without background, it's much more better than with the bones. DSA, we can perform as a single shot, single sequence. And again, the vascularity system of the brain is quite nice, because if you want to see the both, it means the arterial and vein system is enough to inject by one of the arterial trunk the contrast agent, wait several seconds, and the contrast will come back by veins, showing, by the way, all the vein system. So during the one injection, we can see the arteries and veins at the same time. And then, except the single acquisition, we have something the Professor Walewski again mentioned about that, so-called the 3D DSA, which enables us precise and spatial assessment of vascular brain anatomy. We use it mainly for diagnosis and qualification for therapeutic procedures, mainly in the aneurysm and malformation. And again, on the first image on the left, you can and detector is moving around the patient head, and we can receive the 3D kind of film. And as you can see here, it's non-subtracted image on the left and subtracted image on the right side. You can see the same time this is the basilar artery, and the top of it you can see that there is enlargement. This is the aneurysm, and so this is the image aneurysm. And then computer is making automatically for us the 3D reconstruction, and you can see this is even better. The difference is that in this image we can move this arteries in all directions, because in the previous image there was only possible to see for us in the angle of usually 270 degrees. The C arm is moving. In this reconstructed image, we can move it in all directions. So after we perform the TSA, there's a time for the qualification for therapeutic procedures. And if we think what we can do in terms of therapeutic procedures, intravascularity, we have two kinds of procedures. First of all, we can close the vessels. If there is a pathology, we are talking about embolization of, if the artery or vein is closed, we can try to open this, and we are talking about recanalizations. In terms of embolizations, we are performing it mainly during there is the aneurysm, so-called vascular malformations, tumors, or paracerebral hematomas. That is the most common procedures we are using the embolizations. If we are talking about recanalizations, that is mainly about in critical symptomatic stenosis, which is lucky for the patients quite rare, and most often in acute ischemic cerebral strokes. We started with the brain aneurysm. There is a definition. What is it? I'm sure that all of us already know. Professor Walewski also shows some cases. But the most important thing is that it's a life-threatening condition because we don't know the time the aneurysm is going to be broken. And then we have the hemorrhagic stroke, and this is really something which is quite risky for the patient. So what kind of treatment we have in terms of cerebral aneurysm? We have two possibilities. One is neurosurgery, the classical operation, versus embolization, actually what we are doing as a neurointerventionalist. Neurosurgery, as we can suspect, the neurosurgeons must open the skull, they must do craniotomy, then they must go through the brain to the localization of the aneurysm, dissect the surrounding tissue such a way that they must see the junction point between aneurysm and parental vessels, we call it neck or base of the aneurysm, and then they put neurosurgical clip. What we can do is using the usually femoral or sometimes radial access, we must using the set of the catheters. We are going with at the end using the microcatheter. We catheterize the aneurysm sac inside. We must put the tip of the catheter inside the aneurysm sac, and we must fulfill it with so-called microembolization coils. What for? To prevent the blood to go in, because this is a treatment method to prevent the aneurysm to be broken. On the image on the left, this is the standard image of aneurysm on the top of the, maybe not the top, but distal part of the internal carotid artery. You can see the aneurysm sac and the junction point. We call it neck, as I mentioned. But this is quite convenient for us and for the patient because you can see that this neck is quite narrow compared to the biggest diameter of the aneurysm. So it's enough to put the catheter inside. You can see on the right image the catheter inside of the aneurysm sac, and we'll try to fulfill it with the microembolization coils. This is during introducing of some first coils, and this is after the embolization. How we know that we can finish? First of all, we inject the contrast media. The black color means that there is a contrast media in the vessel, in the artery. And there is almost no contrast media, contrast agent in the aneurysm sac. So there is the first sign that probably we can finish. And the second is that there is no space for additional coil. The tip of the microcatheter is going to migrate to the parental vessel. So we can notice such a tendency. It means that there is really no space for additional coil. You can imagine that depends on the size of the aneurysm, localization, and all diameters. And I mentioned that we have different types of embolization coils, microembolization coils, and depends on our experience and the pathology. We can choose the right one. The problem starts if with the neck, the junction point is not very narrow, because then is always the risk that the coil, which is already implanted in the aneurysm sac, can migrate it to the parental vessel. So how to avoid it or how to decrease the risk? If we have almost two possibilities, we have more possibilities, but there is not enough time to talk about it. The most common are the technique, we call it balloon angioplasty technique. There is a case when the neck is not very narrow, but it's not very wide, some in the middle. So we can put the balloon catheter to cover the aneurysm neck, and then put the another microcatheter inside the aneurysm sac, and put the coils as in ordinary procedure. And the goal of the balloon is to prevent the coils migrated to the parental vessels. And I show you using the phantom, but this is recorded with the help of the Mentis company. Is really recorded the real case, and in real time you can see the maneuvers with the catheter. All the maneuvers we must do to perform the embolization with the coils and catheter balloon. First of all, we are going this time from the femoral access. So we are the tip, as you can see, the tip of the catheter is aorta arch. we are looking for the proximal part of the common carotid artery on the left side. As you can see, we must see the vessels to know where we are. So here was the brachiocephalic trunk we are not interested in. The second one will be the right one, the left common carotid artery. We inject the contrast just to check that we are in the right place. Then using the guide wire, which is always going first to decrease the risk of traumatization of the vessel wall. We will, over the guide wire, we will try to push the catheter or microcatheter inside this vessel. Sometimes it's not easy because this artery is usually kinking. There's a kinking of the artery. So usually this is why I mentioned that we are using the set of the catheters, because first of all is the guiding catheter. You will see at the moment. Yes, it's going from down. It's going from down. His support actually the microcatheter to go further, deeper to the brain. And you can see that we are almost in place. When we are in the left internal carotid artery, then we can do the 3D, because as I mentioned before, the 3D DSA is the right examination to assess the assessment in terms of the embolization. So you can see there's the aneurysm. We can make all necessary measurements. These are we needed for choose the right balloon, the right size of the balloon, the length and diameter, and also the coils, because the first coil, the very important is the first coil, because must be as large as possible. So all of this we can do using the right projection based on the result of the 3D angiography. And then you see that we can perform something we love. It really is the so-called the roadmap. The roadmap is the sequence which allows us in real time to navigate with the guide wire and catheter. We are doing based on the fluoroscopy. So we push the button with fluoroscopy, then we inject the contrast, and we are waiting for the best opacification of the vessel, and in this case aneurysm. If we see there is the best time, we turn off the fluoroscopy, and then the last image is frozen, is stopped on the live monitor. And in the seconds, he will become transparent, as in this case, and we are able, then there is one condition, the patient cannot move. So this is why we usually perform it during the general anesthesia. And then we have two images, the real one, using the fluoroscopy, we can observe where we are with the catheter and with the guide wire, and we have this superimposed roadmap. So we know exactly where we are in terms of anatomy and which part of the vessel. So you can see we already have the balloon catheter in place. You can see the two markers. There is the distal and proximal markers beginning at the end of the balloon. Then we start with the embolization microcatheter, which is going as the second one, and we will catheterize the aneurysm sac. First, always the guide wire is going, the micro guide wire. When we are inside, we can start with introducing the coil, the first coil. This coil has the shape memory, so they are creating the loops, and the diameter of the loops is already known by us, is chosen by us. Yet the first coil, as I mentioned, must be as close to the diameter of the aneurysm as possible. So we inflated the balloon, and you can see that even if the coil has a tendency to go out from the aneurysm sac, it's prevented by inflated balloon. So the coil is actually pushed away from the microcatheter. We can, and the idea, because we must remember, but by this inflated balloon, we stop the brain, the blood flow to the brain. So we don't have a time, because it's maximum about 6-7 minutes. We we can have this, we can keep the balloon inflated. So from time to time, we must deflate it in. So we are doing this to allow blood to flow to the brain. But the second thing is that we must assess that there is a stabilization of the coil inside the aneurysm sac, that there is no tendency to go out. So of course, the safer one is to keep the balloon inflated during the embolization, and at the end, we perform the DSA, the control DSA, to be sure that there is all coils inside and there is no contrast media inside the aneurysm. There was a technique we call balloon angioplasty of the aneurysm neck. The second method is if the neck is really wide, is even if the neck is wider than the biggest diameter of the aneurysm, then the balloon is not the best way. We must use the stent, and we can use as you can see here, depends on the situation, on the anatomy of the aneurysm. We can use one stent or two stents, combination of two stents. And here is the case when there is an aneurysm on one of the posterior cerebral arteries on the left side, and it's really not saccular one. I think it's quite a mix of saccular and fusiform. So it means that the part of the artery is enlarged in all directions. So there is no way for neurosurgeons to put the clip. There is no way for us to put just the coils, because then we will make embolization of the posterior cerebral artery, which is not the deal. So we decided to introduce the stent which is covering actually this part of the artery when there is aneurysm, and we are using a special stent. We call it flow diverter, which is a very dense stent, which allow the blood even not to go to the aneurysm sac, even prevent or make the blood difficult to come back. And because of it, there is a blood stabilization, kind of stabilization in aneurysm sac, which really accelerate the process of blood clotting. And after several months, as you can see on the image on the right, there is no aneurysm anymore, because there is inside aneurysm sac is of the hemostasis. And there's the case with the stent. This stent has the structure which is sometimes tough to see. This is why we will use the non-subtracted images. There is again quite big circular shape aneurysm on the distal part of the carotid artery, internal carotid artery on the left side. So we choose the best projection to see the junction point, and you can see that there is inside. We try to make it. Yes. So you can see that there is a distal, distal marker of microcatheter, which is inside the aneurysm sac. I hope you see this red point. And this catheter here, there is a beginning of the stent. There is 3 markers. There is a beginning. There's a distal part of the stent which is already opening, and this is the delivery microcatheter. So the brain stents, all of them are self-expandable stents. It means that when the stent is delivered on place by the microcatheter, then we can come back with the microcatheter, and stent is going to open by itself. So situation once again, the one microcatheter is inside the aneurysm sac. The second one we are using to open to stent, which will cover the aneurysm neck. And this is again the next stage. You can see that the aneurysm is still opening, and the microcatheter is a little bit in the lower part of the vessel. And here is already after the implantation of the stent. Here you see the distal part of the stent, the markers, the construction of the stent, and the proximal part of the stent. The stent is covering the neck of the aneurysm, and here is the coils inside the aneurysm sac. And there's the 3D reconstruction, which is always performed as a control one. You can see on this blue color, it's the aneurysm, the coils in the aneurysm. and you can see also in the artery, internal carotid artery, the part of the stent. Another case is the carotid cavernous fistula, which is, I am talking about that because really it's sometimes we need stand in the using the X-ray, and we must stand really near the X-ray tube, and this is the dose is going up. What is the carotid cavernous fistula? It's usually a result of blunt trauma, and it's suddenly the wall of internal carotid artery is breaking, and is breaking to the cavernous sinus. So you can imagine that the huge amount of arterial blood is going directly to the sinus, to the cavernous sinus. So the vein system is not adapted to such a big volume or large volume of the arterial blood. So it's going back to the ophthalmical veins, and as you remember, the ophthalmical veins, they are located in orbital cavity. So the rapid increase the volume of ophthalmic veins leads to the eyeball being pushed forward, and increasing exophthalmos can quickly lead to irreversible blindness. So this situation, this pathology is not really the life-threatening, but it's very quickly can lead to the blindness, the patient blindness. Unfortunately, there is no good neurosurgical procedures because they're afraid to do it because of the complication connected directly with the treatment. In fact, the way to get to the lesion. So it's usually this pathology is for us, mainly for interventionalists. So there is several types. There is several types of this fistula. The most difficult for us is when there is. I must again show the laser point. You can see this internal carotid artery. Here is the small branches, which is quite tortuous, and there is no way for us to catheterize them, but they lead directly to the cavernous fistula. And so here you can see the enlargement of cavernous sinus. And here on the lateral position, you can see, sorry, once again, I check laser point. You can see that there is enlargement of the cavernous sinus and enlargement of the orbital veins. So we must do something with this. It's impossible to go directly from the carotid artery, from the internal carotid artery, because we cannot see exactly where are the hernia gates, and we cannot catheterize the small vessels. So we decided to ask for help maxillofacial surgeons and go through the ophthalmic veins. So they dissect for us. So they dissect for us the upper part of orbital cavity. You can see the needle here. This is our hand, and so again, with the help of the surgeons, we can catheterize and puncture, and then catheterize the cavernous sinus directly through the ophthalmic vein. So this is the needle, and in the moment, so giving the contrast through the arterial, we can control where we are. And here is I hope that you can see it. We are the marker. This is the microcatheter. This is the proximal marker, and here is the distal marker. Here is the contrast media, and there is the first coils. This is quite a typical site of embolization. Microcatheter, you can see the microcatheter, coils, and contrast, which is actually introducing via the microcatheter. And after all, Before embolization, I hope you remember, it was this enlargement of cavernous sinus. It was before embolization and after embolization. You can see here a lot of coils in the hernia gate, but there was, as you remember, implanted through the ophthalmical vein, not through the artery, as always, and there is no anymore enlargement of cavernous sinus. Arteriovenous malformation is the unfortunately quite often pathology of the brain vessels. It's what is the pathology? It's incorrect connections directly between arteries and veins, because usually it's going through the capillary vessels. In this pathology, there is no capillary vessels, so it means that the quite large arteries are connected directly to the quite large veins, and there are pathology vessels with the brittle and breakable walls. So each even small trauma or increase of the brain pressure, brain pressure can create a problem, hemorrhage. Then the hemorrhage is again the life-threatening. The brain hemorrhage, particular, is the life-threatening condition. So again, neurosurgeons they don't want to operate it because it's the brain. They must cut it in the margin of the health vessels, which is not so easy. So again, the method of choice is the intramuscular embolization. You must put as deep as possible into this malformation and introduce via microcatheter liquid embolization material, which is usually tissue glue or onyx. Professor Warecki also mentioned about that. And the idea is to replace, in fact, the blood for this liquid material, just to prevent the AVM to bleeding. You can see the example on the right side is non-subtracted. On the right, a subtracted image. There is a large AVM in the posterior part of the brain, occipital part, and this is during the embolization, the part embolization, and there is compare on the left side. There is before embolization, and on the right after embolization. There is, and you can see it's disappeared. And at the end, again, it was mentioned before, we have quite big field of treatment of ischemic cerebral stroke. We have two main methods of causal treatment. One is intravenous thrombolysis, is performed directly by the neurologist. The problem with this is that they must start these procedures within the 4.5 hours from stroke onset, which is not very obvious that the patient will be on time in the hospital. If they started over the 4.5 hours from stroke onset, there is increase the risk of complications, and they avoid to do it. So better, it seems to be mechanical thrombectomy, because according to the criteria, we can qualify patients even up to 24 hours from stroke onset. We have two main methods of mechanical thrombectomy. One method is aspiration. If we know based on the NGCT where is the material clot, we can go as close as possible with, again, the set of microcatheters and microguide wires, and we try to localize the aspiration catheter just in front of the clot material, and then we can connect it to the special vacuum suction pump, which is designed, the power of it is designed for the brain vessels. It's not the ordinary one. And it's said that we should wait about 2 minutes with the aspiration, waiting for result. After 2 minutes, we can close. We can finish the procedures if we don't succeed to suck it out. So we have 2 minutes, and we are waiting if we succeed to suck it out. I think that the aspiration method in terms of thrombectomy is the most safer one, because we don't try to pass the clot material, we just suck it. And the second one is Professor Balecki already showed it, is with the using of stent retriever. The stent retriever, it means thrombectomy, which is similar in shape to the brain stent. We must pass the clot material and open it just in the center. We can use the contrast to see that we are really in the middle with this device in the middle of the clot material, and then we can remove it with the open thrombectomy. And this is hoping that he will be attached to the metal structure of the thrombectomy. We can then, of course, making the control DSA. You can see the difference. And the last case I want to show you, this was the case of from our lab, the 67-year-old man. At admission, he was 3.5 hours after stroke onset with NICS 16. Is the neurological classification which is showing us how severity patient in condition of the patient is. The 16 is quite severe. The occlusion based on the angio-CT, it was M1, so it's the branch of medial cerebral artery on the left side. Because he was in good time, in below the 4.5 hours, neurologists decided to introduce the intravenous thrombolysis, but without success. So the patients was transported to our hospital. We started DSA at 4:45 after stroke onset. Started with the planar CT. We have the special dedicated software which helps us to qualify patients for mechanical thrombectomy. So first of all, we must assess how large is the ischemic territory. And we use it with the so-called aspect scale. There is a 10 points. 10 means there is no symptoms of ischemia. 0 means that all territory of medial carotid artery is already taken, is ischemic. So 7 and the border is 6. So below 6 there is usually too much area, is too large ischemia in terms of border of ischemia. So it could be connected with higher risk of complication. Over 6 seems to be okay. So in this time is 7, so it's okay. Then we are performing always CT perfusion. On the green color, they are marked the area which is ischemic area, but is still reversible. So on the left side, there is no. It should be. Sometimes we have the red color area, and the red color means that there is core. Core means that there is irreversible area. So it doesn't matter what we can perform. Anyway, we don't help the area which we called core. This time there is no core. There is always only penumbra. Means that if we succeed to recanalize artery, they will disappear. So again we perform DSR, and you can see here again this is the internal carotid artery on the left side. There is the bifurcation of this artery. Usually here is medial cerebral artery, which is close. Here we are saying that it's amputation of MCA. Here is the tip of our catheter, and we decided to go for stent retriever. So we put microcatheter with the guide wire, and then we will use stent retriever thrombectomy here, and this is the result after use the thrombectomy. We can compare how it was before and how it's now after thrombectomy. And at the down of the image, you have the clot material. We succeed to evacuate it. And it was, I think, the last slide, the last procedures I wanted to see you. But thank you for your attention.
Professor, thank you very much for your presentation. I'm really it's really presentation that is changing the perspective on interventional radiology. This is where ionizing radiation is just a part only of it that helps the physicians. Well, you are also beneficiaries of this project, and I'm very happy about it, because this is because your hospital and center will also be one of the beneficiaries of the project. And now we'll be having coffee break. We'll break for coffee.